Presentation Chest Imaging 4, prepared by Prof. Sharaf and revised by Prof. Yusra Sabri. Again, still we have to talk about radiological anatomy of the chest and heart. In this view, you have the descending aorta down, and then you have the great cardiac veins, and then you have the left atrium, the left anterior descending coronary, left ventricle, left ventricular outflow tract going to the aorta, LCX or the left circumflex coronary artery, moderator band, right atrium, right coronary artery, right ventricle, and arrows indicating the region of the mitral valve. The aortic, tricuspid, and pulmonary valves are normally 3 leaflet valves, whereas the mitral valve is 2 leaflet valve. So the aorta, tricuspid, and pulmonary valves are 3 leaflet valves, whereas the mitral valve is 2 leaflet valve. The right ventricle forms most of the anterior heart border. Thus, it is prone to contusion during blunt trauma. The right atrium forms most of the right side of the heart, right side border, right heart border on the posterior anterior view, whereas the left atrium forms most of the posterior heart border on the lateral radiograph. This is what we call shaded surface display. A for aorta, LA for the left atrium, and here the 4 veins are going into the left inferior pulmonary, LI, the left pulmonary artery, LS, LS is for the left superior pulmonary vein, LV is for the left ventricle, while the RI is for the right inferior pulmonary vein, and RPA is the right pulmonary artery, RS is the right superior pulmonary vein. So remember that the left atrium is posterior and along the upper part of the heart, whereas 4 veins are going into the left inferior pulmonary vein, the left superior pulmonary vein, the right superior pulmonary vein, and the right inferior pulmonary vein. The right pulmonary artery and the left pulmonary artery are at an upper level, Again, the right atrium is to the right ventricle is anterior, the left ventricle is to the left, and the left atrium is posterior, and the mitral valve is in between the left atrium and ventricle, with some chorda tendini attaching to the papillary muscle. D is the descending aorta, and TP is the transverse process, while V is the vertebral body, and SP is the spinous process. Left ventricle, ascending aorta, and from the ascending aorta we have the right innominate, the left common carotid, and the left subclavian. It's not seen here. And then we have the main pulmonary artery segment and left branch. We have the right brachiocephalic, from right internal jugular and right superior right subclavian, forming the right brachiocephalic. Parallel to the right innominate artery. And then this right brachiocephalic vein is going to the superior vena cava and finally to the right atrium. Cardiac surface anatomy and projection is so easy. It's mainly formed of the right ventricle. Black arrowheads point to number 1, the right coronary artery, in the right atrioventricular groove. So we have the right coronary artery running in the right atrioventricular groove, and then we have the white arrows or white arrowheads point to left anterior descending coronary, and then this is running in the interventricular groove. Both of these vessels, the right coronary artery and the left anterior descending, are epicardial on the surface of the heart. Number 5, small arrows are pointing to number 5. This is the pulmonic valve, the valve for the pulmonary artery. So the part appearing above this is the main pulmonary artery. And of course we know ascending aorta, main pulmonary artery, superior vena cava, right ventricle, right atrium, and so on. So the new items here is the right coronary running in the right atrioventricular groove between the right atrium and the ventricle, and the left coronary descending anterior descending artery, left anterior descending artery, or the LAD, is running into the interventricular groove. So we have the right coronary and the LAD. If you check the cardiac surface from above, we have the LM, the LCX, and the LAD. The LAD is the left anterior descending coronary artery you just mentioned between two ventricles. The LAD is running between the two ventricles. The left main coronary is from the left coronary cusp. This is LM, and the left circumflex is the LCX. So we have LCX and left main coronary artery, and then we have the left anterior descending, which is running between the two ventricles. It's called the LAD. The LAD, the LEM, the LCX. Left circumflex, left main, and left anterior descending. Of course, the left are more important than the right. Left main, LAD, and left circumflex. Arrows up are pointing to the internal memory artery and veins. AS is the ascending aorta, DA is the descending aorta, LA is the left atrium, RAA is the right atrial appendage, the PA is the pulmonary artery, and then we have, I'm thinking of, so in the chest PA, the aortic valve is at the left parasternal region and at the level of the third osteochondral cartilage. The undersurface of the aortic arch is at the level of the sternal angle. The aortic knob is formed by the anterior and posterior aspect of the aortic arch. This is an anterior projection for the heart. You can see the ascending aorta, the main pulmonary artery, and number 1 is the right innominate, number 2 is the left common carotid, and number 3 is the left subclavian artery. Standard imaging planes of the heart, in which you can see the right ventricle, the left ventricle, the right atrium, the left atrium, the left atrial appendage, the region of the mitral valve, tricuspid valve, aortic valve, aorta, coronary sinus, and pericardium. On the left is the aortic valve long axis, in the middle is the aortic valve long axis, while on the right is the aortic valve short axis. The second row down is the pulmonary valve long axis, and finally on the right the short axis. Identify factors that may limit the sensitivity and specificity of the examination. Brief reports are far more helpful to the clinicians. Be clear and confident, so delete words and confusing or conflicting statements. Make recommendations for additional views if you want, oblique, lordotic, additional diagnostic studies without treating the referring clinician as left out or a complete idiot. This is how to report for a chest X-ray or any other. We should compare with previous examinations, and reports should be apart. If you are not sure, call the requesting doctor. For example, an immunocompromised patient with evidence of an opportunistic infection, pneumonia is in an outpatient, pre-operative chest with a mass like that. A good report does not always give the answer, but sometimes it clarifies what further questions need to be addressed. Check the mediastinal stripes and lymph nodes. We have finished the how to read the chest X-ray. Now we are going to the mediastinal stripes and lymph nodes. 5 longitudinal lines, 4 in the PA itself. 5 longitudinal line, 4 of them are seen in the PA. One is the paraspinal line. Second is aortic line or the para-aortic line. The third is the paratracheal stripe. The fourth is azygoesophageal recess, and this makes a line along the middle of vertebra. Aortopulmonary window, which is the part between the aorta and pulmonary, as the name implies. T is a fatty thymus in an aged one. But remember that in children, there is a gland. And if you succeed to see a gland in adult above 18, please consider it a tumor till otherwise proved. A is the azygos, while E is the esophagus, and the TS is the transverse sinus of the pericardium, and the stripe is a scapula. S is the sternal body, and R for ribs, arrows for ribs. So what are these? Between aortic knob and pulmonary is the aortopulmonary window. Line seen along with the vertebra is the azygoesophageal recess. Azygoesophageal recess. And this is the right paratracheal line, C for the clavicle, SC for the scapula, SP for the spinous processes. The azygos vein is a thick structure within the azygos fissure, and sometimes it is away from the trachea and thus forming a line reaching to the apex of the lung. It's called azygos vein in the fissure, or the azygos vein and fissure. It's a normal variant, but be careful that medial to this we are just close to the trachea, so this is normal, or away from the trachea. It should be translucent and clear. Deviation or obliteration of the azygoesophageal recess is caused by many factors. Of course, if you have esophageal tumor or mass, if you have hiatal herniation, if you have enlargement of the left atrium, if you have subcarinal lymphadenopathy, and if you have a bronchogenic cyst, these are main causes of obliterated azygoesophageal recess. The right paratracheal stripe is formed by the reflection of the mediastinal pleura against the right wall of the trachea. In esophageal cancer, you should exclude airway obstruction. Displacement and fullness of the azygoesophageal recess to the right in the subcarinal region indicates subcarinal mass or a bronchogenic cyst or lymphadenopathy or left atrial enlargement, as we said before. Displacement and fullness just above the diaphragm is most commonly related to hiatal hernia. So you can differentiate between those at the middle, obliterating the azygoesophageal recess, and those at the just above the diaphragm, which is usually a hernia, but above that it may be left atrium, maybe lymph nodes, maybe subcarinal mass, maybe left atrial dilatation. These are the lymph nodes along the chest. From 1 to 3 is the mediastinal, prevascular, and retrotracheal, and all are single nodes. High mediastinal, prevascular, and retrotracheal. So easy. High mediastinal, prevascular, and retrotracheal, these are single nodes. Then we have upper paratracheal, this is number 2, upper paratracheal, and then we have lower paratracheal, lower down, and then we have subaortic nodes, number 5, and then you have para-aortic nodes. So we have subaortic, para-aortic nodes, and then we have inferior mediastinal lymph nodes. These are number 7, sometimes called as carina. Then paraesophageal, at the pulmonary ligaments down, at the hilar regions, tracheobronchial, hilar, tracheobronchial or hilar, and then interlobular or bronchopulmonary or interlobular. Then you have inside the lung parenchyma, lobar, segmental, and subsegmental. Lobar, segmental, and subsegmental. So together, all together, we have single nodes like the high mediastinal, the prevascular, and the retrotracheal. Then we have upper paratracheal group, lower paratracheal group, and those related to the aorta are the subaortic group and the para-aortic group. and then inferior mediastinal nodes, these similar to carinal. Paraesophageal are lower down, and these are usually single. Then we have mainly hilar or the tracheobronchial, interlobular or bronchopulmonary, and the parenchymal, which are lobar, segmental, and subsegmental. Which nerve, when runs in the aortopulmonary window, there is hoarseness of or vocal cord paralysis, maybe due to mass in this location. That nerve is the left recurrent laryngeal. Hoarseness or vocal cord paralysis may be due to mass in the aortopulmonary window. Again, the question is right or left lateral. It's more important to know right and left copula, and it is important to know the mediastinal divisions. Here, a line drawn along the anterior vertebral column and a line drawn along the posterior cardiac border divides the mediastinum into three: anterior, including the heart and some vessels; the middle, including the trachea and the aorta descending with the esophagus and lymph nodes; and posteriorly is the posterior mediastinum. Right and left is important to check, or better to check left and right, right and left copula. Of course, the left copula is related to gastric bubble, splenic flexure, or splenic flexure, while the right copula is related to the heart and diaphragm and liver, so it is more dense and cause triangular opacity. Anterior mediastinum contains usually the heart, sometimes thymus, lymph nodes. Posterior mediastinum contains the descending aorta, nerve roots, lymph nodes, while the middle has the aortic arch, trachea, esophagus, lymph nodes. So lymph nodes are seen in all. Heart in the anterior, descending in the posterior is containing the descending, while the middle is containing the aortic arch, trachea, and esophagus. But there is another classification. If you draw a line including the heart in the middle, so anterior to the heart is an anterior mediastinum, while the heart itself is the middle, and posterior to the heart, where the esophagus and descending aorta are there, is the posterior. Still, there is a part above the level of the aortic arch, and this is called thoracic inlet. This is called the superior mediastinum. It is from the thoracic inlet to the aortic arch. Thank you.